think about, how aging in place, how aging in your own home is experienced in different places across, let's say, the Western Cape. And so that's where our understanding of these challenges comes from. It doesn't come from our heads. It comes from real people living in real settings and real situations. So here's an example about within the 100 older person households, we work with 96 older persons and the caregivers. Vast majority of the older persons are women. The vast majority of the caregivers are women. This is a very feminized experience. And so we work with them over time. We work with them in different ways. And so one of the key findings, which is outlined in this blue report, which again is available on our online, is that actually challenges with incontinence was one of the main concerns. And that's why we paid more attention to this than we had necessarily anticipated. And those challenges and those costs are multiple. They are, of course, economic. When you do not receive, if you have been prescribed continence wear by a doctor, so it's medically required, and you're expected to receive it at a clinic, and it's not there. Now you are expected to receive it at the clinic. It has been at the clinic maybe on one or two occasions, but you turn up and it's not there. Well, then you're probably going to incur an extra cost of at least 1,600 per month to manage that. And that's not to eat. That's not to travel to the clinic. That's not to even go obtain your SASSA grant. That is basically to live with a basic level of dignity. That's a very high cost, we know. And that, as I said, is a minimum cost. That's when incontinence products are being used sparingly. If you're only using them for nighttime, it might cost you 360 Rand. So the cost of adult incontinence products, needless to say, it will overwhelm your older person grant. It'll take it all over in an instant. And that's not to describe the differences when people have more need or are larger, and the costs are relative to the size and are different across brands, et cetera, et cetera. We don't need to go into all of those details here. Now that's from the perspective of a cost to the household, to the older person. From the perspective of a caregiver, usually an adult daughter or granddaughter, in the absence of such products, a caregiver will spend, needless to say, more time washing, more time using buckets and washing buckets, more time washing linen and laundry, more time washing the older person. That's taking away, first of all, it's consuming a lot of water, which often comes at a cost, particularly in rural areas, but it's also taking away time and energy from both the older person and the caregiver that could be spent in other ways. So older persons may spend a lot less time interacting socially. They may spend less time outdoors because, needless to say, you're concerned about the experience of being incontinent in the absence of such products. It can disturb your sleep patterns. There's many, many costs. There's obviously environmental costs too. So what we saw is across the province, there was an irregular or poor supply of adult incontinence products at the clinics, and that resulted in a very high cost for families. We also saw the cost, as I said, that was often absorbed by an adult daughter or adult granddaughter who needed now to spend a lot more time, consume a lot more water in managing this in the absence of such products. So we have to think of this as a key transformation issue. This is not just an older person issue. In its very basic, it is. If you have adult children, now remembering that 98% of older persons are living at home, in their own home, and that for those 18% of who require support with managing incontinence, it's most often an adult daughter who's doing that work, not only adult daughters, but most often. So they're being absorbed into this, and the cost to them personally, not being able to engage in employment. 1 in 5 of our caregivers left employment or left job seeking because of the need to look after someone. Now, we all want to look after our older persons. That's not a debate, but we also can be supported in that role. There in the presentation, I think you can probably, in your own time, go through the actual experience as expressed by either the older person or the caregiver in in relation to the economic costs, the physical and social costs, the environmental costs. Now, we believe and we know that this is a constitutional matter. This is not something that can be ignored, and this is very urgent and pressing. And I urge, obviously, the committee, but also, ourselves, which we're highly invested in, to continue the fight to ensure that the delivery and the receipt of continence products is improves. Thank you. I'll hand back to my colleague.
Chair, is it okay if we do the last bit?
I go ahead, Doug.
Okay, thank you very much. So we've spoken about the increase in numbers. We've spoken about the challenges that we face in general within the older person sector. We've spoken about the issue of research, lots of research, scientific data that is available, and especially on the continence product issue. And now the fourth area is just to say to the committee, we're not coming to government and expect government to do everything. We're taking own responsibility. We're doing what we can. We try to accommodate older people that cannot afford to stay in our homes, for example. And we cross-subsidize them with people that can afford to pay. We ask families, we basically force them to take financial responsibility for the elders. We're looking at other sources of income and funding. We do fundraising. And we, as we've indicated, we're challenging the national norms and standards. We're looking at how partnerships can assist us to reduce costs so that we don't have to duplicate. And we're engaging everybody that can play a role between private sector, NGO sector, so that we can even there generate more support for those that really can't afford it. So as a sector, we're putting it on the table. We're trying between ourselves to work together as we sit here as an alliance here today. And with that, we're also saying that whilst we take responsibility, there is a government responsibility as well. That government can't shy away from. And although we believe that government is doing what it can, we also believe that a lot more can be done in respect of the Act. And the execution of the Act, as indicated, doesn't only lie with social development. There must be a very close working relationship between especially the Department of Health and Social Development on all these matters, because as indicated, the service that we render in residential facilities, the service within the family context is a care service, a health care service. And that's primarily linked to nursing staff and care staff. It's health related. And the nursing standards and the health standards and all of that must be met. So the Department of Health, we believe, can play and should play a lot bigger role, not only in respect of continence products, but also in terms of issues of medication, mapping of services with us, covering areas that isn't covered at the moment sufficiently with services. So as government, we believe there should be a provincial strategy for older persons that indicates where services are, where the gaps are, where services are required first to prioritize areas of concern, and so that we can jointly work together to cover those areas as the sector, NGO, private sector, with the support of government. So, and that's why we're here today. So we're putting on the table the issue of continence products, but we're also putting on the table other issues that we're not raising here today. But we say we need an ongoing engagement to address those challenges as we go on. And I will speak to the relationship that we have with the Department of Health already. Just on the issue of I still have incontinence, it's continence products. But just on the issue, I believe that previously, many years ago, some of my colleagues here will know, the Department of Health was the custodian of the Act, rendering services to older persons. It then shifted to social development. I don't know when it happened, but it happened, I don't know, 10, 15 years ago. And with that shift, there was an agreement. And I'm not going to read through all of this, but there was an agreement between social development and health that the health department will take responsibility for the provision of continence products for category-free older persons. In other words, those that requires full-time care in a residential facility or at home as per the prescript of a medical practitioner. And the numbers originally was 5 products per day, and this was then reduced at one stage to 3 products per day. So that's the policy position. Whether you stay at home, whether you're in a residential facility, if you're a SASSA beneficiary or a person that receive health services from government, then you are entitled, if you're a category 3, to receive this on the prescript of a doctor. That's basically the policy. So if we look at that, we can look at all the circulars and all of that. Now, the reality is that, as Professor Moore said, this doesn't happen all the time. Sometimes the products would be available. Sometimes it would not be available. Sometimes the medium or the large would be available, but the small isn't there, or only a small is there, no medium or no large. People travel to go to clinics, to go to healthcare facilities. It's there or it isn't there. And she explained the impact on that. There were also issue of the numbers. Some of the areas would provide 5 a day. Others would provide 3 a day. Others would provide 1 a day if they don't have sufficient products to provide. And then there were issues around the quality of the products as well. At one stage, I think it's better now. So the reality is just we need consistency across the Western Cape in terms of residential and community-based services. And I can just give you an example, Chair. We did a survey within Bedisa a few years ago to just check with all our homes, and we've got 50 of them. How many of you receive continence products for the clients with prescriptions that should receive it as per the policy? And we got the feedback. Now, the reality is that within NGO, we need to sell a lot of pancakes and whatever to survive. We need to do a lot of fundraising because of this gap in this. So for us, we can't leave people because there isn't a product available. We need to go and buy the stuff. We don't have a choice. And that costed us as an organization about 2 million rand that year. And for us, that's lots of money, and it's only Bedisa. And because of that, through the Older Persons Reference Group since 2021, we've tried to resolve this matter. There was a letter from SAHA to the Premier's office in 2023. Bedisa wrote to the HOD, Social Development and Health and Wellness, 2023. We then requested a meeting with the Minister for Health and Wellness and the HOD last year, 2025. That eventually culminated into a meeting that we had with Dr. Hilary Goeman, who's here, and her team. And we had a meeting with them end of last year where we raised these issues. And then we had a workshop with the Department of Health, well attended, really appreciated. Dr. Goeman brought in everybody from everywhere to that workshop to discuss the challenges. And as the Alliance, we attended that meeting around especially the continence products. And that for us is the starting point, because once we've dealt with this, we want to obviously deal with other issues as well. So out of that engagement, and you will see it there was an action plan that was developed, a joint action plan between the Department of Health and Wellness and the Alliance on what must be done to address this challenge. And I'm not going to go into detail. I'm sure Dr. Goeman will deal with that. So we've agreed to what must be done. But as my colleague, Professor Moore, indicated, we've got very good policies and plans. It's about implementation. It's wonderful to have it, and we're grateful for progress that we've made since April, especially in terms of mapping of services. We received information, but there's a lot of work that we want to do with the Department of Health and Social Development on implementing what we've agreed to, so that it can really make a difference, and then to do follow-up research and make sure that there's a real impact in terms of what we've agreed to. So we've got a plan on the table. Now, just in general, we've also agreed in principle to form a joint task team between the Alliance and the Department of Health and Wellness that will monitor the implementation of this plan. We must just get this going still. We've nominated our members. And what we want to do is to say, health will work with you on rolling this out, on assisting, on informing, on advising, on sorting out hotspots and how we deal with issues where we identify challenges. And therefore, we came to the Standing Committee today because, Chair, we're working with the department, but you as the political leadership in the Western Cape, you really need to know about this. When it comes to budget issues, it's important for you to take this into account. When you get to your constituencies and you get out there in the community, you need to be aware of the challenges. And when people speak to you about, but we don't get the products, there's a challenge, that you can also raise that and also raise it with the department and also with us as the Alliance. So other areas that we will still deal with in further engagements will be around the issue of supply of medication, the availability of assistive devices, the issue of coverage, service delivery coverage. And we use the example that, with all due respect, in one of the other provinces, your older persons can get their medication and continence products at any Clicks or Dis-Chem. Just by way of an example, how can we be innovative to make service delivery more available so that people don't have to travel long distances? What is the role that the health department can play in future around, for example, the training of care staff, even within our facilities, and to assist us with that? We've got, just in Bedisa, we've got more than 300 nurses and about 1,500 care staff. It's a lot. It's the bulk of our staff. And the service that we render is a health service. It's a care service to those that are frail and those with memory challenges. So we hope, Chair, as we put this on the table, we're not coming here to criticize. We're coming to work together. And that's why we have this relationship now, I believe a good one, with Department of Health as well, and where we can continue to work together, and where you as the leadership on a political level can also continue to monitor. And where we would be more than happy if you can call us back in a year's time and say, Alliance, just tell us about the progress that you've made on the broader issues, and also this issue, and also maybe other issues related to especially the Department of Health. And that's all we're asking. We want to create the awareness, and we want to work with you. Thank you very much.
Dr. Tablanche and Professor Moore, that was very, very comprehensive. And before I continue, we've just been joined by another member as well, Member van Minnen, just for the record, please. Member van Minnen? Maybe Member van Minnen has got some technical issues on his side as well. But what I did notice is during the presentations and at every section and sector of the presentation, I was watching the body languages, and there was nodding all around. Our professionals, DSD, health, everybody was nodding. The members were nodding. And maybe before I give over for engagement, especially to the members, I know we are here to listen and to take note and to take it forward. And I know that the professionals are not probably geared to also engage on this, but I'm going to give an opportunity for, if you do have input, you can make so. But I do know that we came here to take note. We will have our own deliberations as the department and the Committee of Health and Wellness, NDSD. But I'm giving the opportunity. If not, then I will give over to the members. Believe Health, you also have a presentation. Oh, sorry, my apologies. Members, I'm in your hands. Can we go to Health and then we deal with all the engagements afterwards, or how do you want us to do it? Member Van
Chair,
Tuchel?
my
Yeah.
proposal will be that we really deal with this first because it's too much information at once.
Okay.
So it's just a proposal.
I see the other members nodding as well. So Health, let's do that. I'm just going to allow for engagements from the members. Member Van Tuchel? So remember, speak to me.
Except if it's linked to the presentation of Padisa. It's not. Okay.
So what do you propose, member? What are you proposing? I've agreed on your proposal.
Except if it's linked to the presentation of Padisa, then we can,
Okay. It is
but my
linked.
first proposal stands.
Okay, it is linked. Remember, it is linked. Health presentation is also linked. Now you need to change your mind. The first one that we deal with. Okay. Don't gang up on me.
Chairperson, yeah, I am agreeing with the
But
member.
Member Van Tuchel,
Yeah,
that we engage with this
go into
presentation and then we'll go to Health. All right, Member Van Tuchel? Your hand was up.
But anyway, Chair, let me
Colleagues, we're not forced to ask questions because it's been very comprehensive and we understand, and the challenge has been put to us. So it is not that you didn't do your homework if you don't ask questions. We fully understand this and we've received the presentations. I'll make my closing remarks, based on the comprehensiveness of the presentation. So we are not forced. Member Klassen? Member, it's still too early. Now I'm asking if it's still too early because you're not making up your mind. All right, okay, member. Okay, member, for the second time, your hand was up.
thank you for that, Chair. And let me also welcome the presentation. I think you were saying from Padisa.
No, the
It was a
alliance.
Sorry?
We're addressing the alliance.
Alliance. Yeah, not the political alliance. No. But let me welcome it. It was very informative and really you can see the passion while they were presenting. My questions is only on the chair on the 5 identified priorities, the focus areas. I want to understand what the research has been done so far to find cost-effective models for residential vs home-based care. Then secondly, what are the biggest cost challenges facing NGOs and the private sector in caring for older persons? Then when we move to your focus area 2, I want to understand the challenges. What specific challenges will the alliance be highlighting to government and Section 9 institutions? And what initiatives have already been proposed to government to address these challenges? Then, Chair, my last 2 on these 2 focus areas, I want to understand, they mentioned about public awareness. How does the Alliance plan to create public awareness about the plight of older persons? If I can get an understanding, how are they going to do it? And then what do you think the public does not understand about older persons' care? And then the last one on on focus area 4, why is accredited training and development of nursing and care staff an area of concern? If you can explain more there. And what gaps exist in current training? Yeah. I also want to understand what will close the cooperation between NGOs and the private sector look like in practice, and what are the benefits of this partnership for the older persons? Let me park there. Thanks, Chair.
Doc and Professor, I'm in your hands. Are those questions enough, or can we add, or do we do it?
I think maybe we need to respond to these questions, and then we can go to the next couple of questions. Thank you so much for the questions. It's really appreciated. I'm not going to answer all of it myself. At least I've got some very knowledgeable people around the table. So maybe Professor Strubel, if you can maybe just deal with the issue of looking at cost-effective models, and also maybe Elena, I'm not too sure between the two of you.
Thank you, Honourable Member, for the questions. In relation to the first questions of cost-effective models, particularly of home-based care, I think you said of residential care, but of home-based care as well. Am I correct? Yeah. So in our work nationally, we've identified 6 models that exist of variations of home-based care. There obviously are well-known practices, that various NPOs deliver, such as the right to care, for example, in the Western Cape, or other NPOs. But there are other ways of doing home-based care that are, for example, Department of Social Development run in Gauteng. It's more of a peer-to-peer form of care. It's not home-based care as is specifically defined, but it's a version of care assistance. And so whilst we have identified these, we haven't yet costed it, but that is in our vision for the coming months and years. We're waiting for the funding to be received in order to do that analysis.
Something that I just want to add to that, again, thank you for your question, is the lived reality of so many older persons, especially in informal settlements. We were looking at a webinar recently on climate change and the impact. The extreme weather conditions that we have, where in an informal settlement, what we would call a informal dwelling, a shack, the temperatures can rise up to 49 degrees Celsius. Now, that is the place of shelter for an older person. That's where they go for shade. It's 49 degrees. Now, the impact on the quality of life of that individual who cannot go outside, who is in need of care, there is no toilet anywhere near, that person is battling with urinary incontinence. That person will become severely dehydrated and will 100% guaranteed get a urinary tract infection. Now, what we know for an older person to get a urinary tract infection is one of the first signs is confusion. That confusion that that person experiences as a result of a UTI, urinary tract infection, will be most probably mistaken for dementia or Alzheimer's disease, or in certain areas as that this person, is a witch. So, something that starts as so simple is actually incredibly complex, and I think needs to be understood by the Department of Housing, the Department of Transport, and never mind access to medical doctors. We know, for instance, now that NOAA, who runs a number of clinics, that their funding and support for those clinics have been withdrawn. So a lot of older persons who had relatively easy access to a clinic where they can see a doctor, now in the Western Cape, right here in Cape Town, do not have that any longer. I mean, that is unforgivable. Those people are now left to their own devices. They do not have access to a doctor, which means they do not have access to medication because they need a script for it. They do not have access to incontinence wear. I can carry on, but I'll stop there.
Chair, just in addition to that, the review of the national norms and standards, although there must obviously be standards, you cannot not have standards, but we also need to, out of that, look at how more cost-effective services can be rendered. So hopefully out of that process, we're planning to have some pilot projects where we can test the actual implementation of those norms and standards. And hopefully it will be more cost effective. And also within the community, where those norms and standards will also be reviewed to be more realistic and more cost effective. We need to find ways, and I think there are models out there as the NOAA model, on how this can be done in practice. But the challenge is, what we need to do at the moment is legislate it nationally. And we get measured against that, which is quite difficult because it's simply not affordable at the end of the day. Just in terms of the NGO private sector matters that you've raised, member, is I've listed some of the important challenges. The reality is on a bit of a lower level is there's many people in community that's of the opinion that because we're an NGO, we get the money from government and they need to be cared for because it's government care. And it's not government care, it's an NGO. We need to find that money somewhere to make that happen. So there's still this perception we can go there and we'll be cared for. Now, the other reality is that to get nursing staff is a nightmare. So we're supposed to have nurses employed. We compete with the private sector, we compete with government, and we compete with overseas countries to get nursing staff. It's a big challenge. You don't get them. And Christelle will tell you that if you look at at Bedisa again, where we're working, the oldest nurse is now 78 years old, because we take people that can do the job, and we get most of the older people that retired already, because we just can't afford that. I've spoken about the norms and standards that we can't meet. We can't have one carer for every 6 residents. You can't have a nurse on shift every shift. So you've got 4 nurses. I mean, in some of our places, the one that I referred to in Ceres, we've got 1 nurse that works 3 days a week. That's the reality. So if somebody would pass away, and if we look at issues of compliance, and if we look at legal challenges, it's a nightmare, because we can't meet those challenges. There's just no way. The issue of availability of medical practitioners that was spoken to now. And then just maybe also the buildings that we're in was built many years ago, like and it's difficult for us if you must decide whether you're going to spend your money on care of continence products that you must now buy, and not the maintenance of the building. So the buildings, to maintain these buildings, and we believe there are solutions to that. For example, through the Department of Human Settlements, we're supposed to implement the special needs social housing policy, and where that policy makes provision for these kind of assistance to be provided, and it's not. So it is a major challenge, and I can have a shopping list to keep you busy with all of this. Just in terms of the private sector and the NGO sector, what we've initiated first was the alliance, where we have private and NGO sector together, because we come from different worlds. It's for us to understand the environment within which we work. It's, I think, especially for the private sector, an eye-opener. What we've initiated, and we've got Patiswa here from Social Development, is to have the older persons reference group meetings also duplicated within the regions in the Western Cape later this year in October, and then also for those meetings to include NGO and private sector. And the reason why we want the role players to get together is, first of all, to see which policies can be shared, which resources can be shared. There's sometimes, with all due respect, some of the private retirement villages that would throw out some furniture that we can use, by way of an example. We also want to work together and say, who's covering which areas? How can we use your nurse? We can't afford 4. Can we help you and use your nurse, for example, to oversee the implementation of home-based care? How can we work together to cover better? And that's where we need to find ourselves as we roll this out. Public awareness. We've got a team, Victor Southwell, that unfortunately isn't here today, and they're taking responsibility for advocacy and awareness. And what they're doing is to cover the issues of social media. They doing weekly placements on social media on challenging issues, whether it's about the training of carers, whether it's about continence products, whether it's about whatever the challenge might be within the sector, to create more awareness. Elena?
Just so, honourable member, in relation to that question about public awareness is one of the most important parts of this work. And the reason I say that is because, Chair, you stated that everyone was nodding in the room, and this is a room full of people who work with this kind of stuff every day. Every individual in the country has their own experience of looking after an older person. We've either done it, we're going to do it, we have been looked after ourselves. There's a lot of assumptions taken for granted as a result of that. People will say, politicians and others will say, well, in my family, it happened like this, so why can't they do it? Why can't families just do it, right? And so there is an assumption that families can do it. And what we're trying to show is that actually families can't do it all. Most families are very willing, and most adult daughters, nieces, nephews, etc., are very willing and want to look after older persons in their own home. But there are situations we know that it's not possible, whether for a range of reasons. One, mainly because the actual complex nature of the care that is required, not because people are trying to abuse the situation or they're trying to misuse the situation. And that is what we are trying to do with public awareness. Explain and show that this isn't a silent private issue. This isn't just an issue in your house or your house. With the population reaching almost 20% of older persons, 1 in 5 people in the country will be older in about 20 years, 25 years. And therefore, it's a structural issue. We're all going to be doing this. So we need to build structures. Otherwise, first of all, our hospitals will be flooded, but not just our hospitals. A whole range of other institutions will not cope. The system, the society will not cope. And we need to kind of demystify and change the idea that actually to look after your grandmother is expected of you alone. It's not expected of you alone. People need support in both the looking after and being looked after for multiple reasons. And because we have these laws and policies in place, there are expectations on the state and private sector and NPOs. And so that's one of our biggest, not just challenges, but one of our most important exercises, is that if everyone thinks that this is a critical issue, which it is, and it's a policy imperative, which it is, and it's a growing issue, which it is, it's just as important as, or more than important as childcare, as many other forms of care. Thanks.
You go first.
Sorry, I'm going to address the question on training. Thank you for the question. I'm going to try and answer it like this. If you're a young person who wants to be a care worker today, you have to achieve a SOCWA accredited training program that is listed under the QCTO's regime of available qualifications. The only 2 qualifications available today are a home-based carer training course and a personal assistant to the home-based carer, neither of which comply with requirements of the Act in terms of the areas that must be covered in training. The background of these two training courses is that they were developed by Hospice South Africa, in particular to address the need for home-based care of people living with HIV/AIDS and tuberculosis. And then there's a small bit that's been added on for older persons. The kinds of training that we need a carer to have coming into a place where they're, or a community service where they're looking after older persons, goes significantly beyond the training curriculum that's in those training courses. So if you ask why we're concerned about training, we need proper training courses available from QCTO, which is the governing body now, for carers to learn. Many of us have carers in our employ who are not certified because we have to use the carers that we get. And so that means that we're strictly not in compliance for those particular carers. Some of them have been in our employ for many years and are very, very good carers. But so we are trying to close the gap, making training bridging programs available for those people, or trying to get them fast-tracked to QCTO training. But even if they get those certificates, which I must tell you costs up to 18,000 Rand, and even to write an examination can cost you 3,500 Rand. Many of these young ladies, mostly ladies, are single moms just trying to get onto the employment ladder. And so it's almost an impossible task. Yes, we do get the odd scholarship from overseas funding and so on for some carers, but it's a dire, dire situation. And the problem that I have is this is legislated. It is a requirement. So we should be complying with it. And the minister should prescribe specific training that covers the areas that are listed in the Act. Unfortunately, that's not available. The training that was developed by the Department of Social Development was done under the old regime of CETA-based education, which is no longer allowed. The last registration was in June of last year for those courses. And so we have nothing to train care workers for the needs that we have at the moment. I understand that the department is working on moving that training towards QCTO accreditation, but that in itself can be a 2-year process. And so if you ask why are we concerned, I think that is the reason.
We say thank you to those responses, and I'll give over to Member Claessens.
Thank you, Chairperson. First, let me allow me to congratulate our new Minister of Health. I'm also new like her in the position. And then secondly, wow, I'm very concerned now. You guys are doing an excellent job out there in our communities, and I can relate to most of the stuff that you've presented here, because we stay in communities and access to medical services and Medicare, it's a big problem. So let me first say thank you for the service and the passion that you have to do this on a daily basis. Not a lot of people wants to work with old people because they get written off in society. But I think somewhere in the presentation, you are talking about a new generation of older persons that needs Wi-Fi, and some of them are on TikTok. So thank you for the service. To the minister, this is a very serious matter, because a country that can't care for the older people, the people that built the country, that contributed so much, Chairperson, to our economy, especially in the Western Cape, we owe it to them to look after them. I am concerned that 26% of funding of the Western Cape budget has decreased to a percentage of 26%. That is unacceptable to me. I represent a patriotic alliance, but we can never support a decline and a decrease in finances or in funding to such a critical piece of stakeholder in the community. I think the decrease should stop. We will bring a motion to this parliament to address this issue. Secondly, we cannot have a once-off meeting once a year with you guys. This government needs to, this parliament and this committee needs to build, Chairperson, a much stronger relationship where we meet at least quarterly so that we can be briefed, because we are the lawmakers in this province. And if we take decisions where we are uninformed or where we don't have enough information about a particular sector, then we will continue making uninformed decisions. So I welcome this session because it's an eye-opener. I was not aware that there's such a huge decrease in budget terms. We cannot allow that to continue in the next 5 years. So I will call on the new minister. Let's build a stronger relationship with the NGO sector dealing with older persons, because they're the most vulnerable in our society, and they need access to the stuff, the products, the Medicare that is there. We cannot allow a situation where the nurses are not subsidized anymore. This government needs to take a complete mindset in terms of addressing this issue. So I welcome this. I just need to know, Chairperson, in the plan of action, there's a proposal to set up district and sub-district health forums. Is there any progress on that in terms of the establishment of that forums? And if there are certain areas that is not, where is it not established yet, what is the hiccups there? And how can we take that forward to see that those committees or structures are set up in the different districts? Thank you, Chairperson.
Member Clarkson, as a new kid on the block, I gave you grace. The comments you have raised, you'll have a second bite on that when we are dealing with recommendations. But most of the stuff that you've reached on, we do have the answers as a committee. We're not going to provide it now in front of the Alliance, but we will take you through it. But you will have a second bite on your concerns as well. I'm now going to give over to Member Walters online.
Yes, thank you very much, Chair. Also just want to thank you for the presentation, or through you, thank the Alliance for their presentation. I like the depth of research here. Well, also during the course of your answers, I had 8 questions and I'm reduced to 1.5. So it's 2 very simple questions. The one is, in terms of the cost of healthcare products and cost of the incontinence products as well that you referred to, have you done research on what the cost drivers is in the market itself? What is making it more and more expensive? That's just a very specific question that I have. And then secondly, I completely agree with your comment that you said earlier that everyone has a particular experience, and it's not necessarily the same as the next person. It's a very complex field to assist people. You outlined a number of concerns in capacity. You highlighted the extent of the problem as well. All very good data, but is there a particular model on a community level, that a particular example or a particular research that you've done that is scalable? It's something that is cost effective and scalable, that you can refer to, and perhaps also maybe specifically in a particular area, because that might be relevant for the committee as well. Thank you very much, Chair.
Thank you, Member Walters. Doc and Prof, I'll give over to you.
Chairperson, I'm so glad that I've got 2 professors here. that they can respond to this. So I'm going to ask between the two of them. Elena, if you can maybe kick off.
Thank you, honourable member, for the question. You asked firstly the cost of healthcare products. What are the drivers in the market, the cost drivers? I mean, I can't answer that. What we did is we asked and accompanied older persons as they and their caregivers as they purchased and used and consumed such products, and what was the cost to them. I think maybe colleagues from the Department of Health will be able to talk about the procurement of adult incontinence products. So I'll leave that to them if that's okay. The second question, though, however, is whether we have particular examples of models that are scalable, that are cost effective. I think I alluded to this in the answer previously. We have identified such models that are best practice, because remember, like you say, you're balancing a whole range of complex factors, not just whether it's cost effective, but is it good quality, etc. And is it scalable for very different conditions across different provinces or communities or whatever. So that question is still in production as such. We ourselves require more funding to be able to do the actual analysis, although we have identified 6 or 7 models that exist and that could be built upon and tested whether they're scalable. So I suppose that the answer to that is wait for the space, I suppose, or perhaps we can team up and provide more analytical work. Thanks.
If I may just go back to the cost drivers, I think something that we need to consider again, and I can elaborate on it extensively, is the implication of cheap incontinence wear. This is not just a nappy. This is something that, as my colleague said, talking about dignity but can have serious medical, clinical impact if it is not a product that is acceptable and of a high quality. So obviously, when these products are not available from the clinics, people will go out and buy, incontinence wear that has been made, locally and not in South Africa. I mean, in a backyard somewhere. And the health implications for an older person to wear incontinence wear like that is dire. So yes, it's a very complex positioning to find incontinence wear products that are really acceptable and of a good quality to avoid those clinical and health outcomes.
Maybe before the Department of Health would respond to the cost issue, we've actually, my colleague Christel Klopper did some research last year where we actually compared various incontinence products in the market. And we wanted to compare and look at quality and look at cost effectiveness. And out of that research, there were certain products that we've identified as the ones that we would like to use within our organization. But what I want to raise is, as part of that exercise, we've also looked at the product that was procured by the Department of Health in the Western Cape. And I must say that the product was of a good quality. There wasn't a major problem with quality of the product. It was simply around availability and the correct sizes and all of that. But the product itself was not of a poor quality when we compared it with the leaders in the market. So I think, we need to acknowledge that. Thank you very much.
Thank you for the responses. And before I give over to Health, I'm going to try to be a nice host. How about if we take a 15-minute coffee and tea break and we can rub shoulders, and then when we come back, I'll then give over to Health to do their presentation. So we will be back at 11:15. We'll join you in the members' lounge for some tea and coffee. Thank you. Members online, we will send Uber Eats to you.
We're just waiting to be let in.
Member Van Vogel, I know I cut you short. You still had another question. So maybe we can go for your question whilst we're trying to get health online.
Thank you, Chair. Mine is on the, do you call it the population aging? Yes. I want to understand what I pick up there is that when you look at Eden and Overberg, it's a decrease when it comes to the aging population. Am I missing? Are we there? Wat ons die ding sinne? Can I ask?
If I look at the slide, if you look at Overberg, in 2001, it was 10.1% of the population, and it increased to 12.2 and then 14.7 in 2022. So there is an increase, and the same in Eden, it was 9.5, then 11.5, and then 14.8% of the population.
So that means there was an increase when it comes to Overberg and then Eden.
Yes, yes.
And what does I mean in terms of your, what do you project for 2032 as per your second table? And are we ready for it? As per your second table?
Yeah, the second one, Chair, I know there's a lot of figures there. If you look at the third last one, the total column there, okay? And if you look at the first one, 2024, we had 836,000 older people. This is now for the whole of the Western Cape. So I don't have the breakdown here for each district. One can get that. It's not a problem. But that 836,000 will increase to 1,131,000 by 2032. So, but the information is available per district within the Western Cape. I just didn't have that detail in the presentation.
The last one, Chair, is what do you think, sir, the reason for the higher population in the rural areas versus the metro? What do you think? What is the reason?
I mean, generally speaking, we don't have the minute data, but if I were to guess, and I have spent a lot of time in the Overberg and worked research in the Overberg, you've got an aging white population generally, right? Who more people who are in that category, let's say 60 to 100. Remember, these are percentages, right? It's percentage of the total population. So in the towns, whether it's the city of Cape Town, or you have far more young people, young being under 60 in this regard. So the percentage is different. So it looks like Overberg and Eden and the likes have a real problem. They do have, I mean, they are aging disproportionately faster than like Cape Town. But it's only because Cape Town's full of more younger people. Cape Town also has lots of older people too, but as proportion to everyone else in the area, it's slightly different. I shouldn't have gone into the white story, but that is also true.
Thank you. We are covered. I'm now going to give over to Health to do their presentation. Thank you.
So much. Chairperson, you can feel free to slow me down. I'll try and be swift, but because I don't want to repeat too many things,
Sure.
but slow me down if needed. Thank you so much. Just an overview of our presentation. I'll fit on purpose, strategic overview, then just our key milestones for age well, the adult incontinence, which was surfaced today, current interventions with regards to that, reflecting on our draft SOP that's coming out from there, and then what's happening in the rural and the metro district.
Sorry,
health
Doc, can you
services.
just, the mic? Yeah.
What's happening in the rural and metro health services, support, and then some of the way forward. So just the purpose, I think we're all in agreement that we're here to discuss the current health-related challenges affecting older persons in the province and to present some of the interventions that we are putting in place within the department. Just to bring alignment to the strategic overview and our framework for action is really how we're cultivating a care system. And I think I'll just pause a moment here. So the framework for action focuses on the strategy for action as well as the intervention areas across the life course. It's embedded across the 4 value propositions. So start well, 0 to 18, 18 years, live well, looking at the age population 19 to 59, and then age well, 60 plus, and then of course within a system that runs well. So just in terms of our strategy for action, if I can focus on age well specifically, excuse me, if I can focus on age well specifically, what we intend here is to develop a care system that is capable of supporting older people to function with fulfillment and a feeling of well-being. The health system's capability for preventative care, promotion of social inclusion, functional re-enablement, and then supported end-of-life care. That's our 4 focus areas. And essentially, where do we want to go with this? We want older people to be resilient and to have agency to attain and sustain best possible quality of life. So what happened was in June of 2025, in response to this strategic intent, we developed an age well forum with some of the role players in the room and various other role players from other government sectors, as well as higher education and other partners, and really looking at how we would respond from a community perspective, as well as support to the residential space. And this is just a reflection on what has come out of that. We worked together to develop an age well position paper for the department that guides how we will take processes forward. So older persons in the Western Cape, we acknowledge face significant health, social and system challenges that undermine healthy aging. So there's multimorbidity, functional decline, I think one is our biggest challenges, social isolation, another massive challenge, caregiver burden, I think it was reflected on earlier on, as well as fragmented services that reduces the independence and the quality of life. So we acknowledge that ageism, poor care coordination, and limited evidence for planning further weaken the support. And so together, these factors highlight the need for integrated person-centered approaches that strengthen prevention, coordinated care, social inclusion, and end-of-life support as part of our Age Well Forum. These are the 4 priority areas really for the Age Well program. Essentially, it is maintaining independence through functional re-enablement, reducing isolation by addressing social inclusion, promoting health and reducing disease burden, and here's really about preventative care, and then of course ensuring dignified person-centered care, particularly in the palliative space and the end-of-life space as well. I suppose the main thing for us is to say that, it's so easy to focus on aging population, our older persons surviving, and we do that through various preventative mechanisms, but they need to thrive, and essentially we need to transform how we respond to that. So really here, our focus is on strengthening the key health system capabilities, which includes data systems to know what we're dealing with, our diagnostics, our vaccines, medicines, as was alluded to earlier on, which is also a gap in certain areas, our equipment and assistive devices, which was also flagged, and then to support prevention and early intervention as well as quality care. So moving from strategy to action, and I think that's the big thing. It's so easy to have a strategy, but for us to move to action, our focus has really been on bringing it home. So here we, within the context of the community-oriented primary care, we look at how at the lowest level, we engage understanding the disease burden, understanding the demography of the population, and then how we respond to that. So I think our big focus actions here, or our key actions here, besides prevention, is rehabilitation, mental health support, home-based care through COPC, social participation programs, accessible environments, and improved transport, which is also another challenge. And I think staff training, which was also raised earlier on, because even in the department, we acknowledge that we only have 2 gerontology specialists, I think, in the Western Cape, of which one is close to retirement. So, and then also in reintegration into our basic undergraduate training, which we acknowledge is also requires attentions for all the clinical disciplines as well. And then our focus on palliative care, and I think our policy in the palliative care space has been intentional on integrating palliative care into the public sector services and reduce our dependence solely on hospices. Which is our key partner and support, I must add. So towards an age-well population, I think here just to focus on the fact that we've aligned our age-well program to the which is an evidence-based response to population aging in the Western Cape. And I think the data that our colleagues have presented just proves that point. We're aligned to the UN Decade of Healthy Aging, and then, of course, the Integrated Care of Older Persons approach framework as well. I think despite ongoing resource and data challenges, it's, we're putting forward a proposal in the position statement that allows for flexibility, a whole system approach, and also acknowledging that not every community is the same and that context matters, and that in certain communities we have more older people with more needs, and in other communities it looks differently. So I think there's full acknowledgement for that. Maybe just to quickly reflect on the key milestones for Age Well, and I put up this timeline from 2009, where we put out our first memorandum of agreement between ourselves and the Department of Social Development. We then moved from there into a circular that was posed in 2012 around our category 3 clients and the incontinence products, which has then evolved over time. In 2013 was consumables, and our requisition form that we would put in place for some kind of processes to support our residential facilities. Then there was an update on the standard operating procedure for adult incontinence, which was followed in 2016 with a revised consumable list and requisitioning form for community-based services facilities. 2024, a task team took this forward to review the process forward to review all our circulars and conduct a situational analysis to see where we're at, because acknowledging the fact that the population has changed significantly for older persons, that then led to a situational analysis that was conducted with the Department of Social Development. They funded residential care facilities to assess the number of clients that were eligible to receive the adult incontinent products. And then in November 2024, we put out a memo was sent to older persons, the reference group, really, and the private sector as well. So the Department of Health and Wellness provides updates with this regard to that particular forum. We moved on in 2025, as I said earlier on, with the Age Well Forum. We've then drafted a SOP for adult incontinence products. Was developed with inputs from various colleagues to inform, which was also then informed by the situational analysis that was conducted in 2024. Then in March 26, we represented, not sure if it's me, the Age Well Forum workshop feedback and a draft position paper, which was then eventually signed off, I think in last month. And essentially we're moving forward with regards to this. So lots has happened in between. We've had visits to the warehouse, looked at the quality of the products, visited some of our facilities to look at how products are dispensed and where some of the challenges are. So that is a work in progress as we take it forward with the district health services. In terms of adult incontinence, and I think maybe just take a moment here. I think we're acknowledging the growing burden of incontinence in older persons. I think that's a global reality, with urinary incontinence anywhere between 43 and 77% in our residential facilities, and dual incontinence at about 47%, and in community dwellings anywhere between 30 and 50%. So in South Africa, I think our prevalence is about 1 in 3 women. There's low help seeking. We've acknowledged that under 25%, and minimal specialist continence care capacity in the public sector, which is also requires a lot of work. I think in the Western Cape, our highest provincial aging index we have in South Africa is in this province, with 832,000 people aged 60 plus. And I think that data has been updated in the schedule that our colleagues presented earlier on. So we do have the highest demand for adult incontinence care currently. Then the impact of adult incontinence, and I think that was raised earlier, so I'm not going to spend too much time on it, but I think the knock-on effect is obvious that if we don't have that in place, we do have a massive cost implication that comes with pressure ulcers, etc., for the state, but also for the family and the household. And I think acknowledging the fact that the family and the household is impacted by that, the community, as well as an economic impact. The provision of adult incontinence products. So we have a memorandum of agreement between health and DSD that we are busy revising. We have a standard operating procedure that acknowledges that category 3 clients, we're looking at about need to require this maximum assistance with activities of daily living, and they are mostly bedridden. And then, of course, in our residential care facilities as well. So what we do is we provide the adult incontinence products based on prescription. These AIPs, which is our acronym for it, is in this discussion refers to adult diapers, to pads, and to briefs as well. And then, like I said, the accepted norm is per client is 3 adult incontinent products per client, which then results into approximately 90 products for the client for a month. And I'll go into the costing a little bit later. Just to again say that I think essentially our goal with a revision of the memorandum of agreement between ourselves and DSD is to promote active aging and protect older persons and keeping them in families and in communities as long as possible, but then well supported during that process as well. In terms of our contract that is in place, and I think our colleagues have reflected on the quality of the products, just to flag what that looks like. So essentially, we have got a contract in place now until May of 2027. We have a list of approved contractors that's linked to that contract. Our sizes range from small to extra large, and there's full acknowledgement that we need to look at sizes beyond extra large. Our cost, maybe just to flag, so if a client receives 3 small diapers, adult diapers, per day, which works out to 90 per month, that's around about 6.5 packs of 14 in a pack. So the cost based on our contracting, it works out to 549 Rand per person, and the extra large works out to 683 Rand per person. So we have a SOP in place to request the stock, to also put in complaints of any kind, and then also just to say that the Service Priority Coordination Directorate, which Dr. Goeman is the head of, is engaging with contract managers regarding the inclusion of the larger sizes. Just to give a sense of what the budget looks like, we had a budget of about 30 million Rand for the last financial year. The budget was overrun to about 36 million Rand. There's full acknowledgement that the problem is inequity. Some of the districts are underserved. There's also challenges with wastage. We have often clients who are deceased, families don't bring diapers back, or they continue to collect, or clients move to other areas and there's still a collection process in place. So that's things that we need to be dealing with, and we are dealing with, especially through our new SOP. And we're looking at moving to clinical governance, ensuring that we are able to provide the products. But I think what we need to be clear on is that the budget currently still requires further increase in order to offer that kind of support. I mean, we did a bit of a back of the matchbox exercise, because we know that it's not, some of the clients remain on the products for a few months, some for years, but the budget is really something that requires further attention. And then also just to indicate how our the SOP gives us insight into our processes that we follow, how the residential care facilities are supported through their submissions, their orders, their daily use. And for the clients at home also, it's referral. There's a clinic collection either by the community health worker or by the family members. And then, of course, with hospital discharge, that is something that we're busy putting in place with the new SOP, that clients are not discharged from the hospital without anything. And then there's a massive gap between the time of discharge by the time they present at the primary healthcare facility. So these are all new changes that we're putting into our SOP. Our way forward is a revised contract, as I indicated, with the Department of Social Development, to map our needs using GIS mapping for underserved areas. There's ongoing interrogation of the data to identify where the challenges are with regards to stock and with regards to budget. But I think the bottom line is from buy and send to prescribe, track and audit is really trying to create responsibility along the line as well for ourselves and for our clients. Then this is just giving a little bit more detail on the standard operating procedure. So really, so here is about once a client has been assessed, this is how we start with client identification at a residential facility identified by the medical officer or the nurse working in that space. In the community, it would be by the primary healthcare facility, or the NGO usually has our community health workers or our registered nurse that works in that space, and then of course in a hospital setting. So then the next step is the clinical assessment to determine eligibility, and then to basically refer the client through a prescription mechanism and documentation. So it's prescribed usually for a 6-month period. The quantity is 3 per day, and we then explain quantity and review processes to the client and to the caregiver. Like I said earlier on, our hospital discharge, we're working on that initial sort of pack being issued with the client, and then our documentation to ensure that the client can continue further is to give a client a copy of the prescription for discharge from hospital as well, and to pull the process through. That same copy is then provided to our supply chain team at the facility that ensures continued ordering from there on out. So again, this is our SOP. This is some of the changes we brought into the space to just tighten up things and refine it adequately so that we don't have wastage, but that we also try and work better on the provision. I thought I'll just flag maybe here for metro and rural health services. These are the residential facilities that are being supported. I'm not going to go into detail, but according to the 4 substructures, there are 84 residential facilities that are supported. And then, of course, there's lots of ad hoc that pops in from time to time. In the metro, the support is in the form of clinical and medication care, nutrition and consumables, and incontinence support, and then community rehabilitation and capacity building. We have the detail of that if anybody would like to have that. And then in the rural setting, as you will note, in Central Karoo, and we know that there's about 1% of the population in Central Karoo, there's only 4 residential facilities that supported in that space, but there's 68 across the rural districts. Similar process here, also clinical, medication care, preventative care that's offered, as well as consumables, incontinence and assistive devices. And then, of course, coordination of home-based care support and capacity building that is ongoing in those spaces. In terms of our way forward, system strengthening is what we are working on. Strengthening our policy, not just the development of a policy, but the actual implementation, standardizing the eligibility criteria, finalizing that SOP, conducting the capacity building and the updated standard operating procedures, and then, of course, our updated MOA with the DSD. We'll also be moving forward into interdepartmental alignment and role clarification between ourselves, DSD, and various stakeholders, integrating service delivery, so that we embed it within the geographic area and the ecosystem as well for those residential facilities, as well as our NPOs. And then, of course, partnerships and stakeholder engagement, which I think we've been working very deliberately on, strengthening our NPO partnerships and enhancing those partnerships like we have the colleagues in the room, so that it also gives us the bigger picture. And then, of course, continued DSD engagement meetings. Our systems and data communication, lots of work happening in, and we're acknowledging that it requires more strengthening is in the communication pathways, enhancing our monitoring and evaluation, and then really laying the foundation for better information systems. Our costing models is an ongoing process, and I think we can acknowledge that the budget is overrun, but it's still not providing the need on the ground. And then I suppose creating awareness of the complaint system is also quite important. So I think that just gives us a sense of where we have been and where we are at. Thank you so much.
Thank you, Doc, for that presentation. Members, I give you the first bite if there are any comments or questions. Member Van Voorthuizen.
Thank you, Chair. Chair, let me also welcome the presentation, the Department of Social Development. Oh, it's our department. I'm so used to the HOD. But nevertheless, I'm not sure then if my question is going to because I thought it's going to be because the budget are actually under the Department of Social Development. So I'm supposed to ask them these questions, but I want to understand in terms of the MOA, your memorandum of what do you call it? Memorandum agreement. I say a beautiful English word. You signed that memorandum, I think, years back. Cost of living have changed. Things have changed. Was there any process to review and to update that MOA?
Shall I respond? Yes. So we currently in a process. So there was work between 2009 and 2014, for revisions. And we're currently in a process with DSD to finalize the MOA. In between, we had COVID, we had staff changes during that period that, contributed to the finalization of a signed document, and that's the one that we currently are busy working with the colleagues that's actually in the room from DSD.
Just the last two. Thank you, Chair.
Follow-up, yeah.
The last two questions. Then I will take some of the questions for recommendation to the Department of Social Development, Chair.
Okay.
But then I want to understand in your MOA, you speak about well-being, safety, and rights of older persons. How are you combating abuse of older person when we look at your objective, if when social workers and NGOs are understaffed? How does your funding protect the dignity and right of older person who cannot afford private care? Or, yeah, thanks, Jay.
Thank you. Yes, you may.
I think my colleagues from DSD will probably be better positioned to respond to this. But what I can say is just based on how services are rendered at the lowest level, our role is mainly in helping to identify that through our community health workers and the community-oriented primary care approach, and then to escalate that to colleagues within DSD. We also have social workers within the Department of Health and Wellness that also play a pivotal role in order to identify that, and there's physical abuse, emotional abuse, there's financial abuse, which is one of our biggest challenges, and even abuse with regards to medication, with some of the medication, especially scheduled medication for pain management and things like that, and palliative care patients, where that's also a risk for some of our older persons.
So you're earning your salary today?
Chair, mine, I will say the last question now. It was in the presentation of Badisa, there's a problem with the education part or training. And my understanding, there's an intergovernmental approach. So the departments are working together, taking consideration the issues raised by Badisa, the challenges that they are facing. Have they brought it under your attention? Were there engagements between the three departments? So I assume it's social development, health, and education. So if I can get an understanding if there was such discussions, and was it actually on your table? Have they tabled it? Thank you, Chair.
Just for the record, member, issues raised by the Alliance. We are in an Alliance meeting today. Yes. Yeah, that's a familiar term for you folks.
So I suppose the only response I can give is that we've been working on particularly our own staff and our own training gaps with regards to geriatric care, gerontology, etc. In the undergraduate space. We do also train community health workers in the foundational training with regards to support and care for older persons, and that training is opened up. Beyond that, in terms of, I think what the colleagues from the Alliance flagged was also at an SACWA level, those kinds of things. So that's not, we haven't gotten involved in that space because, I mean, in terms of our mandate, we've been focusing on community health worker training, as well as professional nurse or clinical disciplines, shall I say. And that is a gap. I'm acknowledging that is a gap and that is receiving attention. Yeah.
Your last bite, we're running out of time.
Thank you, Chair. There was also issues raised with the service. Now I'm speaking to our department. And you are the custodians of that department. Clinic, the access to health care when it comes to older persons. Was there engagement? Is there, what do you get progress in terms of serving those vulnerable people?
Yes, member, that is an ongoing process. It has been an ongoing process. So we've got regular engagements with the Alliance. We are addressing it with the district health services. So as we become aware, there's an ongoing process of addressing that. Yeah.
You'll have a bite when we deal with our committee staff as well on that. Just to be fair, any clarity seeking questions from any Alliance member through you, Doc and Prof, based on this presentation, before I make my closing remarks?
Chair, I'm not sure about the other members, but I'm fine at the moment. If everybody is okay. Yes, please.
Thank you, Chair, and thank you, Doctor, for your presentation. Just a question. If we consider that incontinence is not a normal part of aging, you spoke about the fact that we all know that it's very underreported and that most GPs do not inquire around it, as the research shows. You said that you are updating or improving your screening tool. What screening tool is being used at the moment? And is there a program to educate older persons about the fact that, you know, of all the sort of 7 types of incontinence, most of them are transient? Because I think often it's a first port of call that people would, you know, administer incontinence wear, which then makes a transient problem a chronic problem. So what is the department doing in that respect?
Shumai?
So I can only say to you that it's probably clinician by clinician basis, right? So every clinician would have to assess the client and make that call in terms of how they're going to be dealing with something that might be transient that could then become chronic. But the first part of your question.
What screening tool is being used?
Yes. So we've been working on a screening tool that that has been developed over time. There's a task team that's looking into it. I think Helody's just pulled it up on a phone now. It's also based on research and evidence, and it's in the process of being finalized now. Family physicians have gotten involved. We pulled in people like Leon Geffen and others from the Age Well forum as well, to help us to, you know, to develop that so that it's evidence-based and not just a thumbs up. And I think the main thing was that that's supposed to help us to identify the eligible clients in a way that we can then make sure that the eligible clients receive those products. Yeah.
Okay. Thank you. Thank you, Chair.
Yes, ma'am, at the back.
In the presentation, I just want to clarify something. It says on the continence products on discharge issue from hospital, it's 1 pack, which is 30, and then it says it's 2 week supply. But for a category 3 resident, in our residence, it should actually be 3 per day.
May I respond, Doc?
Yeah, I think that is an error. So historically, the patient is discharged with literally 1 nappy. If they're fortunate, and they get told to go back to the day hospital. What we've put into the new SOP that we're busy finalizing is we are proposing 14. The 2 week supply, I think just ignore that because we're acknowledging that it's 3 per client. So we must just revisit that because we acknowledge that the client or the family will not necessarily get to a primary healthcare facility quickly enough, or the patient gets discharged on a Friday or a Thursday, they can only get there the following week. So it's just to tide them over until they can get there. So that's what we are putting on the table and proposing for our SOP moving forward. And then maybe just a last point just to flag is that the palliative care task team has also played a critical role in the development of the eligibility tool for those clients as well.
Professor?
Yeah, thanks, colleagues, very much. It's fantastic to see this and all the updates and changes or revisions and strategy. On this slide, the slide with the adult incontinence product strategy, the step 1, 2, 3, 4, the problem, the new rules, how it flows, and the way forward. When you look at the problem, obviously there was budget. The second one says inequity, that certain districts were underserved. Do we have any more explanation as to not just the why, but perhaps the where? Is there any deeper understanding of that, or is that, or even if it's in a document, I can go read it myself somewhere? Thanks.
So we haven't shared the situational analysis that we've conducted. So we've picked up pockets of areas. It's not like one district or one substructure, but it's pockets across, and that's what we're busy addressing, yes.
Any closing remarks, if any, from DSD? Are you sorted?
I just want to say the District 6 Community Health Centre is one of the best practices, and I agree fully with you there. But there are others which are terrible. And we really, and some of our, from RCVT, some of the most vulnerable facilities, or the facilities with the most vulnerable people, they are in some of those other facilities. What are you going to do to uplift them to the same standard as the District 6 best practice facility?
Thank you for your question. I think the workshop that we had with all the stakeholders in April, we were very intentional to bring the service colleagues into the room to make sure we establish those local connections so that we don't wait for issues to be escalated, but that it can be addressed at the local level. So I think that's also part of our intention to improve the communication between our various stakeholders so that we don't wait for issues to, become extreme, and that we actually can service the population that we know we're there for. So I think there's been improvement since April. I'm also aware of specific challenges that was raised, and as they were raised with the communication that's now in place, immediate action was also taken, and some positive feedback was then also received when these issues were resolved. So I think the communication between stakeholders and more so at the local level is of utmost important for us as we move forward and we strengthen, the partnerships moving forward. Thanks.
Let me give to Doc
Yeah.
first, and then to the
Okay, I
gentleman.
just want a word before your closing, Chair.
All right.
Okay.
Sorry, Mr. Chair, just a comment on there. I think there's two things in South Africa that works very well. That's the taxi and the courier industry. And maybe if when the member of a memorandum is between DSD and Department of Health, and we sit with rural areas where people have to go kilometers to go and pick up the nappies, maybe involve these type of courier companies to do their corporate social investment that they have to put back, and maybe invest in doing the door-to-door services with a guy like Courier Guy or Take a Lot or any of those, where they then register the nappies with their SASSA card or whatever. So it's just a suggestion.
It's a brilliant suggestion. Lady at the back.
Not a question, just something I wanted to raise, a comment before we close, is that I know this looks at category 3 clients or patients. I just wanted to raise a group that's missing. So we know in South Africa, 1 in 3 women suffer from prolapse, and we know with the prolapse comes incontinence, and the older the women are, the more incontinence they have. if I can speak from my personal experience with my grandma, she's on 4 incontinence pads a day, and she's not included in the category 3, so she doesn't get pads. So we have to buy that, and it's a very big expense. So I think that there's a gap. Like these people are not included here, and like I said, it's 1 in 3 women in South Africa. So it's a lot of women. Thank you.
I want to respond to that.
Yes, so you're raising something that we've flagged already. In the new SOP, we are not going to be focusing on category 3 only. We basically unpack all other sort of eligibility. So I know we still speak to category 3 clients here, and I think it's a acceptable categorization. We know, but the eligibility doesn't just lock it into category 3 clients. Yeah, thanks.
Dr. de Blanche, your closing remarks before I abuse
Chairperson,
my own powers.
thank you so much. I think from our side as the Alliance member, just a word of appreciation to you, Chairperson, the members, the Minister, for the opportunity to provide you with this information that we share today. As we said, we are available to work with the Department of Health, and we'll continue to work and to strengthen that relationship and to keep the channels of communication open so that we can really address this. We're also available, Chair, if there's a need, and we would love to believe that there will be a need for the Standing Committee to call us back and to report on progress. And we will be making time available to do that. So you're more than welcome to call on us, or if you need further information, you're more than welcome. And then at the end of the day, as you would know, the proof of the pudding lies in the eating. And at the end, we need tangible results ourselves with government so that we can really make a difference and we can say we've actually implemented the plans and it's making a difference at this location and this location and that location, because then we will know that we've made a difference. Thank you. We really respect you. We appreciate it. Thank you.
That's a pleasure, Doc. And my closing remarks, I'm in a very advantageous position because I'm the chairperson of health, and with myself and some of the members, we also serve on the committee of DSD. So we concur with both presentations, challenges and opportunities that can arise from the challenges. We concur with that. So we definitely know where to put shoulder to the wheel. And with these presentations, the officials, in the meanwhile, they will go and dissect it and do what we have to do. And we as politicians, within the next 2 weeks, we're going into constituency period because of the elections. So I want to commit and to promise, and I want to agree with member classes that after the elections, let's say next year, let me commit to next year because after the elections, we're going into December. After the elections, we totally agree that this should not be our first and last engagement. And we definitely need to meet on a regular basis. We can sort out the terms for those engagements going forward. And based on that, I would like us in the meanwhile, especially the Alliance, during this period, if you can, I'm now giving you homework, if you can be specific in terms of what is it that needs to be reviewed with the national norms and standards so that we can then zoom in directly in terms of at the higher level through the ministries, the 2 ministries, on how we can approach that to make sure that that gets onto the agenda for discussions going forward. And then also, fortunately, with the new minister now, Member Kaiser Philander, just last Friday, we had a discussion in terms of how can we make it more affordable for the institutions which you folks are running. And what came to mind is that there's a sphere of government that we leave out due to probably ignorance or because we're not at that level, and that is local government, the municipalities. Because some of your expenses are rates and taxes, and the municipalities, they don't negotiate that. They just invoice you, and that is it. And I have not discussed this with my Minister of Health yet, but I do think that when we come back, DSD, health, and local government, we need these three ministries needs to sit down and see how can we get the municipalities on board, maybe to have a flat rate based on the needs and based on the accounts for your institutions. And then maybe that can also be a relief to a measure in terms of the budgets going forward. I don't know what form that would take, but it is definitely something that we will pursue. And then I'm just thinking of my notes. And then the other thing probably also as part of the homework, the clicks and discom operations in other provinces. What are they doing that we are not doing in the Western Cape? So that we can also bring that to the table. And when we start negotiating with the people who will be signing a new memorandum of agreement or understanding, the taxi guys, the courier guys, maybe we can bring clicks and this scam also on board to see how can we make it easier. So that would definitely then be the first points for next year to make sure that in the follow-up we deal with these matters, but then nothing stops us in terms of the technologies that we are having to continue the conversations. So what we can deal with that does not need to wait for a committee meeting, then the professionals can then deal with that. But then from my side, thank you very much to the Alliance. I've learned a lot, and this is definitely the route to go going forward, because we can only fix what we know, what the issues and challenges are, and we can only get that from the people who are working on the ground, because we do our spot checks when we do oversight visits and whatever, but you can only do so many oversights in a year's time. But you guys are there every day, so this is a definite learning curve for me, and is definitely something that we're looking forward to. And between ourselves, we're now just going to bring local government on board as well to deal with that other issue. But DSD, thank you very much. Department of Health, thank you very much. And to the Alliance, we're going to come and have coffee after the elections in some of these challenging areas that you're saving on. Thank you very much. And members, you can remain behind. We're now going to dissect what you have given to us. Thank you. Well, engagement, yes. Yes.
Just physical copies.
All right.
Oh, okay. These are all fairly national, but
Okay.
it's provincial level data in there. And this is what we're doing. This is where we.
Oh, yes.
Exactly what needs to be done.
Okay.
A lot of it is national, but there's some provincial.
Yeah, we can engage with them. Yeah. Thank you, Prof. Okay. All right.
okay.
We're going to go into your website as well and just make sure, yeah. Thank you. Okay. Thank you very much. Thank you. Thank you. Thank you. Thank you.
The face, very good. Yeah. Thanks a lot. So much. Thank you. That is how you got to encourage that agreement between health and social development for people in residential facility. Because remember, we went and people always say that transport, when these old people get to the facilities, they are not catered for.
Yeah. Arendse. Really better. Members, thank you for your patience. I know it's been a very full agenda and program, and we are 10 minutes over time. We're going to take less than another 10 just to wrap up. Members, whilst it's still fresh in our minds, any recommendations? I think, Member Claassen, your recommendation that there should be future engagements of this kind with the Alliance going forward, we'll take that as a recommendation. We'll decide as a committee next year on the what is it called? The interim times on when and how many times do we envisage to have these engagements. We'll take that one. Yes, member.
Chairperson, the concern that I've raised about the budget, the decrease of budget, how are we going to deal with that one?
Okay.
Because I know that maybe the Department of Finance is also the main department responsible for finalizing budgets. How are we going to deal with that one?
Okay, member, we're already in a budget cycle. So there's another cycle coming up, and then in the new cycle, we can definitely engage on that and just make a mental note somewhere that when the budget comes up, then we have a thorough look into the budget when it comes to how do we deal with the matters from health that can relate to DSD. Member Walters, I see your hand.
Yes, Chair, I think it would be very useful to have an industry analysis done of the medical care products industry to understand why, both from a distribution point of view as well as from a pricing view, what are the cost drivers, what are the complexities, and perhaps that is something that has been done at some universities.